All right. Hey, everybody. Welcome to our last pre-med meeting of the fall semester. Um, if you need to sign in for attendance, you can use the QR code, and Callie sent the link in the chat. So go ahead and do that. And let's get started.
So I just want to talk really quick. Red and White Week, also known as Homecoming, is coming up. I'm part of the Alumni Association Student Ambassadors as well. So we actually put on all of Homecoming Week. So it's going to look a little bit different this year, obviously, because of COVID. But we have our kickoff on Sunday. So that's going to be a drive-through event, but you can get t-shirts and a bunch of other gear like that. We have Paint the Town Red that's actually starting this week. So we'll be painting businesses on Hillsborough Street. You can sign up with a group. And you can also participate in these events at home as well. We have networking night. So that's with every college. That'll be Monday night. We have a lot of good panelists set for that. And then on Tuesday, we have a tradition scavenger hunt around campus and virtual Tuffy trivia. And there will be prizes involved with all of these. So that's a quick glance at that. And then Wednesday will be the day of service. So I just wanted to share this with everyone. You can go to that link right there and sign up for any of these service events that are around Raleigh.
All right, and now we're on to our guest speaker, Dr. Brian Hodge. I actually met him through a service trip I did with the Rural Health Outreach Club earlier this year. It feels like forever ago, but it actually was just about 6-7 months ago. So welcome, Dr. Hodge.
Thank you guys for having me. So my name is Brian Hodge, and I live out in Henderson County, Western North Carolina. I'm a family physician by training, and I work as the Director of Rural Health Initiatives at MAHEC, which is the westernmost mountain area AHEC across the state. And so the whole point of the AHEC system is really to decentralize a lot of health education. And so I'm in charge of a lot of programming, not only family medicine residency programs out here, but also a lot of pipeline programming to really encourage people to go into health careers and really figure out how we can promote equity throughout the region by creating different pathways for a diverse group of health professionals to really be the workforce and provide community-based care throughout the region. So Ryan, we were able to meet just a few months ago on campus. He and some of his classmates came out, and he invited me to speak to your group, and I'm really happy to contribute in any way. What I thought we would do is, do a brief presentation on what is rural health and why it may matter. And hopefully that will provide you some information and some inspiration as well. But then mostly I wanted to be available just to answer questions and hopefully guide a discussion. So I have just a few slides if I can share the screen. And in the meantime, if you guys don't mind, putting into the chat group exactly where your hometown is, and if you've had exposure to living in a rural environment where that has been. So, all right, I'm going to try to share my screen here. Oh gosh, let me see. Okay, I'm going to do it again. All right. I think I'm sharing now. And I'll start. Can you guys see this all right? So this is a talk that I've given that really kind of lays the land of like, what is rural? Why does it matter? And what can we see in Western North Carolina? And this is the stuff that I'm working on a pretty regular basis. So, my main objectives here today are really to give you an idea of what rural populations look like, articulate why their areas, particularly for high impact for primary care interventions, summarize what health inequities exist in rural areas, and really describe the competencies or the tools that you may need to really thrive as a clinician in rural environments. So, and you know what, Ryan, I may need to ask you to chime in with some chat box stuff, because I can't see it when I have my screen up and running. So we'll go through what is rural. And so this is the state of North Carolina. And so the darker green areas are the areas that are most rural. The micropolitan areas are the light green areas, and the white areas are the more urban areas. So, I mean, it's a pretty green map. So North Carolina, not only is it a large state, but it actually houses, it houses more rural people in it than many of the states across the country. And so there are actually more than 15 definitions for what rural actually is. And so for some people, rural has to do with census information, but for other people, actually, it's whether or not they have a Dollar General, a Target, or a Walmart in their county. And so, and I think actually, when you look at the numbers, those three things can really give you a sense of how rural your environment is. So, oh, I'm going the wrong way. There we go. So the technical definition is really anything that is not urban, which is kind of crazy when we think about it. There's metropolitan areas, which are going to be anything greater than 50,000. There's micropolitan areas, which, depending on which definition you look at, that's going to either be 2,500 or 10,000 to that 50,000. And then if you're considered rural officially if you're below that micropolitan area. And so it actually makes up approximately 20% of the population, over 75% of the counties, and that actually plays itself out for North Carolina. It's actually 80% of our counties. We have 100 counties in North Carolina, and it actually comprises close to 60 million people in the United States. And actually some of the worldwide leaders in rural medicine are actually Canada and Australia. And our 60 million, that number of people that are rural within the US is actually more than the total population of Canada and Australia combined. So it's a lot of people. It's predominantly family docs, and this is kind of the picture of what rural medicine used to look like. This is on the plains of Colorado. This was on the cover of Time magazine when we still had, periodicals that are going to be at newsstands. That time is kind of come and gone, but they actually did a recent expose on this photojournalism piece. And it really takes you back to a different time and different place for medicine. And so why does rural matter? Ryan, do we have some people in some hometowns? Are there some rural hometowns listed there at all?
I haven't seen any yet. Y'all can go ahead and drop them down there. I will say I'm from Rocky Mount, North Carolina, from Nash County. So we definitely do live in a rural area. Somebody just said Pasquotank County, Hope Mills, Stanley County, Wayne County.
So a handful of rural folks. So that's great. Well, I think when we try to figure out how do we make a difference, I think the US has some of the worst health outcomes for developed countries. And, one way to kind of, take on that overwhelming problem is to try to figure out, well, what's driving that number? And so I think that speaks to why rural actually matters. So when we look at this, this is a life expectancy versus health expenditure. And as it should be no surprise to you all, the US is actually this outlier out here. Most of the developed countries are going to have a higher life expectancy for a lot less money. And this is like a per capita. So effectively in the US, actually at this point, we're over $10,000 per year per person, which is, well above any of the other developed countries. And what do we get from that? We get, a life expectancy that's actually gone down 2 years prior to this past year. And I think it's kind of plateaued off here in the past year. When we look at that from an urban and a rural lens, we actually see that, it's actually a health disadvantage to live in a zip code that is rurally designated. And so you lose 2.5 years of life just on average across the board. And so we can see that actually in the state of North Carolina as well. There's a fascinating study that actually looked at this over the course of the last 50 years. And so not only have we been trying to do a lot about it, but we've actually seen that number has actually increased. The gap between the rural and the urban disparity, that's actually gone up in the last 50 years, despite substantial interventions. And so you can see that the age-adjusted mortality is improving kind of across the board, but it's improving at a slower rate for your micropolitan and your non-core counties in North Carolina. And so the subsequent question that you're going to ask yourself is really, so what's driving that? Is it patient safety being worse in those places? Is it the fact that they don't deliver person-centered care? Is it that they don't have access to the same amount of effective treatments? Or is it a lifestyle and just an access question? And so when you look at this, actually, patient safety is about equal, person-centered care is about equal, and there may be some, less access to effective treatment. And there's certainly a lifestyle aspect of it, but probably one of the biggest drivers is just less access to care delivery across the board. And I think, I bring up this slide. These are the urban-rural health disparities, and this is North Carolina again. You're going to see, the tendency for people to focus on all these areas where this gap is worse. So drugs and alcohol, suicide, years per life loss, injury, access to exercise, teen birth, all those things. But actually, rural counties will have more social capital. They tend to have, a culture of we can do it. And so I think that as we look towards really figuring out solutions, I think it's important to really leverage those things that already exist in rural communities to try to figure out how do we use this social capital to promote better health behavior and really solve some of these problems that have led to this gap. So I think we're going to see some substantial themes here with, poor populations across the board. We're going to see older populations in rural areas, less insured people, and a lower health literacy. And so we see that pretty much across the board. So these are rates. In gray is the nation as a whole. And as you get more and more rural, that's going to be darker blue. And you're going to see that poverty rates, childhood poverty rate, and elderly poverty is all across the board higher in rural areas. Additionally, you'll see that complemented by worse access to care. So fewer doctors. Before, we said that almost 20% of the population lives in a rural area. Well, physicians account for less than 8% of physicians live in rural areas. And so as a result of that, there's further travel to care, there's smaller hospitals, there's less specialty care, and there's less resources across the board. And so there's this thing called a HPSA score, which will define where there's the greatest workforce shortage area for primary care. And so the red counties in Western North Carolina, these are all the ones, as you get more and more rural, those are the ones that are going to have the higher HPSA score, just meaning that there's a lower density of physicians in those areas. And so we can see that pretty consistently there. And so as a result, we'll also see worse metrics for chronic disease, whether it's heart disease, cancer. Unintentional injury ends up being a big one. And I think that has to do with the types of jobs that are available in a rural environment. But it probably also has something to do with if you are unintentionally injured in a rural place where you don't have much access, you can imagine that the travel times are going to be longer to get yourself to care. And then there's also going to be worse lung disease and higher incidences of stroke as well. Health behaviors complement that as well. So you're going to see higher incidence of smoking, worse alcohol issues, and alcohol in Western North Carolina ends up being a big driver in our rural communities: alcohol, drug use, and hepatitis. Obesity rates tend to be worse in rural environments. And then ability for exercise and sleep. I think sleep is actually kind of just across the board. It's pretty equal everywhere. So that's actually not much of a rural urban disparity. So that may be a learning point. It's the one outlier in that respect. And then we also have this concept about the diseases of despair. And so that's going to be substance abuse and mental health services, so suicide rates and so forth. And you see it on social media. The NRHA is a great resource for a lot of these things. And you're going to definitely see a higher suicide rate in rural areas. The mortality in Appalachia in particular is actually higher for these diseases of despair, rates of overdose, suicide, as well as alcohol liver disease. So every place, if you just look at Appalachia as an independent rural entity, you're going to see higher rates for all of those diseases. And we would also say that Appalachia disparities are really driving some of the national trends. So if we can actually figure out ways to reconvene the system to provide better care in Appalachia, that would actually also make our national numbers improve. And so that was what a major white paper that came out in the last couple of years demonstrated. So, and I'll kind of descend briefly to the particular, these are all the counties in Western North Carolina. The place that most people know about is going to be Asheville, which is in Buncombe County, right there in the center. And so I think what you'll see with this map, it's a little busy, but the darker green area, the lower median household income is. And then the numbers that are listed in each county demonstrate their county health rankings. And then the ratio actually demonstrates the physician to population ratio, or the population to physician ratio. So you're going to see in a place that's a largely urban area like Buncombe, there's going to be, for every physician, there's approximately 700 people. And the national average is about 1,200 to 1. And so you can see there are several counties that are meeting that mix of physician density. And what we see is a pattern where, say we go out here to, I'm off here again, sorry. I don't know what happened. It reversed me. I'm gonna get caught up here quickly, sorry. I don't know how my screen got pulled off there. All right, here we are again. So if we go out to Rutherford County, you're going to see less physician density. You're going to see by far worse health outcomes. And so you can drive into the county health rankings and try to figure out, well, okay, why is that? It doesn't look like it's actually the uninsured rate. It's actually, like, if you look down there, it's a really high proportion of children living in poverty. So if you were going to do an intervention to try to do something upstream of that, you really want to drive at, what are the main determinants that are going to be contributing. And so similarly, if you look out at Madison County, there's actually, very similar physician density. It's a lot more proximal to the urban environment, and it has this decentralized health system out there that really each kind of neighborhood pocket or holler, if you will, has their own health clinic. So it provides a lot of great primary care access. And so as a result of that, you can see that actually they score higher on preventable hospital stays. So I think it's really important to kind of get familiar with your regional data and really try to figure out exactly what type of initiatives would make a difference, regardless of what physician you end up training to become. Out in Swain County, which is consistently kind of in that lowest tier, there's a lot of drivers that, demonstrate that their rankings are worse than the state averages, and things like smoking and teen births are certainly probably going to be driving some of that inequity. And then places way out in Cherokee, which is probably the most isolated place in Western North Carolina, or probably even in North Carolina across the board. There's high rates of unemployment, children in poverty, and then we also see the injury deaths contributing there. And many of these things, it's not only access to medical services, it's also a lot of social drivers and the economy of it all. So North Carolina has this great database where you can geomap all the social determinants of health. And so this is kind of descending to a county census data on, say you wanted to do a outreach event for, to make sure Latinx community is getting better access to healthcare. This would tell you the percent of households that it has limited English speaking. And so you could know where to do some of those outreach. This would give you a sense of where, there's a percent of single parent households. And so you can see what could be driving some of these health inequities that we're seeing. And when you put this all together, if you look at transportation, education, housing, and occupations, you can put together a Z-score, which is their social determinants of health score, and you can really try to figure out where care coordination would make a difference, and where are the places that have the least advantage when it comes to health equity. So that kind of gives you an overview of what's happening in Western North Carolina, and how, like, in a little pocket of our state, we have a lot of different diversity. We have diversity of many different rural communities, and there's certainly a lot of room for improvement. A lot of people will say, gosh, we need more physicians. And it's not only that we need more physicians, it's actually probably even more so. We just need to make sure we're putting physicians in the right places with the right skills so that they can better serve their communities. And so we're going to talk a little bit about rural solutions here. It's about recruiting people to the right places, making sure that people from rural areas get access to attending medical school, make sure that the right placement programs are in place to give financial incentives for people to go to a rural community and really fall in love with the rural community. And then it's keeping them there and keeping them happy, which often, actually speaks a lot to economics. It's not just about recruiting physicians to rural areas. Our rural areas have to be desirable places again, and they have to have vibrant economies that people are going to want to send their kids to schools and see families that are in a similar situation. And as physicians, you want to make sure that they can practice in a way that they feel like they're safe and they're making a difference as well. And to speak to that, I really specialize a lot in making sure that physicians have the right skills. And so that involves competencies and really having, broad-based training and exposure to a lot of different environments so that you can actually be adaptable and perform the best services for a rural population. And so some of the key skills to look forward to as you go through your medical education would be adaptability, how to perform when there's scarcity of resources, how to promote resiliency, integrity, and also how to collaborate with others. And so those are going to be competencies that you look for, especially if you want to practice in a rural environment. And I think a lot of people get a lot of joy despite working long and hard hours in rural environments. And that's because they're able to feel like they actually are making the difference, that they're able to practice in a way that they feel like they have more autonomy over what they're doing, and that they're more connected with their community, and they really feel like it's a calling. So, and then once again, I just want to emphasize, as you go through training, I love the fact that you guys as a group are doing some outreach, early on before you're going into medical school or any health profession, because I think the more you're connected to community infrastructure, housing, transportation, our working environment, food, education, income, and race and ethnicity, the more proximal you are to those issues, the more you're going to be able to make a difference. And so I really like talking a lot about how do we practice in a different way. I mean, our current model probably is not providing the best services for all of the people that we're trying to serve. So, how do we do initiatives that remove the barriers that make substance abuse or substance use disorder easier to treat? How do we make sure that we're doing outreach in rural areas for geriatric populations? How do we work best as a team? how do we make sure that you're not only being, providing services, but I think a lot of people are attracted to rural environment because you actually get some leadership as well and a lot of opportunity there. How do we make sure that all the early screening and interventions are going to be, available and readily accessible for rural populations? And I think we really have to be creative, and sometimes working in a rural environment can give you an advantage to kind of rethink and pilot some innovative things. So, and I look to you all actually to be the shepherds of that type of work. And I love seeing these eager faces up here. So I think the major take homes, and then we'll go through discussion points, but overall, rural populations are going to be poorer, older, less insured. They have worse health outcomes and access, worse health behaviors, and a higher death rate. And this systematic health problems are really amplified in rural areas. And I think we've also seen that actually in our COVID work as well. Some people will like to say, COVID is driving the inequity gaps that exist in our health systems. And I would actually try to pivot away from that and say, our inequitable systems that we've built have been vulnerable to the threats of a major pandemic. And I think that's the way we got to talk about it. Zip codes and addresses matter. Think about the person, place, and the time. And really, I would, if I had any advice to give myself when I was kind of going through my earlier education, it would really be to take my time, stay open-minded, really concentrate on the relationships. And when I think of my mentors that have made the biggest difference for communities and for people, they've been the ones that have really built off of those relationships and longevity in a community. And I think that's the stuff, that's how we make a big difference. And the rural skill set, and really being able to kind of be like a Swiss Army knife out there and have a lot in your belt. I think that's applicable in any practicing environment, especially if you're trying to take care of underserved populations. So we do a lot of work with global. Global is local. That's one of our themes. And so we'll do global outreach in Honduras, but then also make sure we're taking those lessons here home and trying to figure out how in our own community we can make a difference because, some of those inequities are right there in front of us. So I often want to at least close with some inspirational quotes that we're standing on the shoulders of giants. And so of all the forms of inequity, injustice in healthcare is the most shocking and inhumane. And so I think we all play a role in not only, acknowledging that, but also making a difference with it. And Wendell Berry is a great philosopher and novelist that, a community is the mental and spiritual condition of knowing that the place is shared and that the people who share this place define and limit the possibilities of each other's lives. And I think that speaks to just being present and immersing yourself in your training, in your neighborhood, and whatever problem you're trying to solve. And then the health needs of the American family are changing, and so much the physician who services these needs, the physician of the future will greatly differ from that of the present. And so this was actually written many, many years ago. And so as much as it has been inspirational to me, it'll be inspirational for all of us, just knowing that this isn't a static training experience. Like, this is committing yourself to ongoing training the rest of your careers. And I quite frankly find it invigorating. So I have a list of resources, and I'm really happy to share some of this information with you. I also shared some information on internships that are available through MAHEC. If you're, Ryan can circulate those, but I'd love to open it up now for a discussion.
Hi, so I asked in the chat earlier, we were going over one of the graphs, and I think you mentioned that social capital in rural areas is higher. What
Yeah.
exactly is social capital?
So I guess I would turn it over to the group. What do you guys think social capital is? How would you guys define it? Put it in the chat and we'll see if we can solve that question. Mohammed, that's a very good question. No, is it a sense of belonging? It's a sense of community? Um, an ability to share with one another. I would say that those would all speak to it. It makes me want to grab that study and really say, like, how did you characterize that? And I think they actually did it through survey questioning and people, like, answering some question on, how tightly knit is your community? What is your sense of social capital? And people in rural environments tended to score higher than people in urban environments. That brings up, and I think I was trying to say this and I didn't emphasize it quite enough. Every rural environment is a little bit different. And so I think that's one of the most fascinating aspects of my job is really seeing, not only the different health systems and how they interact with the community, but just how, historically how, one county will look very similar and be right next door to another county. However, the culture there can be substantially different based on the types of jobs and the type of families that settled there initially. So,
how does that impact how, like, you would practice medicine in one rural area versus another?
Yeah, so I think there've been a lot of study here recently on the interaction between patients and different types of care providers, like physicians in particular. And so I think that one of the things that, you don't necessarily get explicitly trained this in medical school, but it's really important to develop that connection with the people that you're taking care of. And so I think that if you come from the same background and you look the same way and you have very similar beliefs to someone, you're able to connect with them much quicker. And so knowing those things, I do think that there are skills that you can develop to be in tune with, hey, this is what the culture is here. And so I think that keeping an open mind and trying to figure out ways that you as a physician can connect with the people that you're taking care of, I think requires of you to get to know that community really well. And whether that means living in the same neighborhoods that they're living in, or whether that means, going to the same church, or, being exposed to their family or doing community events with them, I think that will give you the right frame of reference or context that you're going to be more effective at trying to encourage people either to do healthier behaviors or just encourage them to be able to connect and listen to you and respect you as you try to help them kind of navigate healthcare decisions. It looks like we have some more questions here. Why do you think rural health doesn't attract physicians? Is the salary lower? So it depends, honestly. So is the salary lower? That, in some areas it is. In other areas, salaries are actually higher. And I think that depends on a lot of local factors and some state, policies that really determine how practices get paid. Let's say you were a surgeon, and as a surgeon, you could do 300 gallbladders per year in a urban environment. And you move to a small town and you could only do 120 gallbladders per year. Do you think you're going to get paid the same? Probably not, honestly. And so with our current payment structure, you get paid by the number of procedures, or as we call it, the fee for service. And so that, when you look at smaller communities, that's going to be different. And so it's an interesting economic exercise because many times hospitals will try to pay doctors more to move to areas because it's harder to recruit to there. But if you recruit them to there, and then those same hospitals that are paying those doctors really can't recuperate all those fees, it's a really, really testy model. And so I think that that mismatch there has been driving many of the hospital closures and causing a lot of practices to close over the course of the years. So other countries have figured out a lot easier ways to do this, but even when they have kind of, a transparent salary scheme to recruit people to rural areas, like in Australia, Canada, and Northern Ireland, all those places have systems that are really a little bit more innovative at recruiting. They still have a hard time just recruiting people to smaller areas to live and making sure their spouses have employment opportunities and so forth. So I think one of the keys, though, also is just to figure out how can we, go to a rural area and make sure that we have programming that's going to encourage the best and the brightest from that area to be able to really dream about becoming a physician and returning back there. And I think that's a key to the success as well. All right. Well, we got more questions. You guys are doing awesome now. Sammy, do you want to ask your question and then I'll try to answer it, just so that we can have more people talk than me?
Yeah, for sure. So recently I've been very interested in like how 911 works and just like the overall emergency, like EMS, fire, police and everything. So I'm just curious, like in rural counties, what the wait time would be for like ambulances and how it would be different, and like how it affects, like how it's different from rural counties to non-rural counties.
Yeah, so you're gonna see larger travel times, larger response times, and there are all sorts of challenges to that. I had a patient that honestly had a cardiac arrest while he was at a rural lake, and I think it took him 2.5 hours to get him up to Asheville, and he passed away. And I mean, he was, honestly, I had done a physical on him the week before, and all he had was high blood pressure and he smoked, and it was devastating. So that is, I mean, honestly, that's something to take into account if you are, going, out into the wilderness, that those travel times do make a difference. We work with EMS a lot. And so here's another problem that, it's similar to that, but it kind of turns it on its head a little bit. In Graham County, it's so difficult to get in to be seen at the urgent care or at any of the primary care offices, that the culture has become that people will call the ambulance because they don't have transportation and they can't get an appointment with a doctor. So not only do they do that to get to the ambulance, but then that ambulance has to take them 45 minutes up the road to the nearest hospital, one county over, when they just have a cold, right? And it's getting worse. So, I mean, and so as a result, I think that county has the highest per capita or per person Medicaid costs in the entire system. So, I mean, that's a big problem. So I think taking into account, and being familiar with the way your systems of care are delivered is really important and have to be a part of the conversation. So both for urgent measures, especially if you're having accidents, but then also just like, how do we make sure that the common stuff that could be handled by an urgent care or primary care provider is so readily available that they're not, that there isn't this misuse of our transportation systems. All right. So Ryan Taylor, do you want to tell us about Franklin County?
Oh, yes. I just mentioned in the chat how I work with EMS in Franklin County. And if we have anyone that has a actual, like really serious medical emergency, we have to drive probably 30 to 40 minutes to get to Wake Med, to Duke, to Chapel Hill, wherever we need to go so they can have access to the correct care. So I've experienced that firsthand, but also I didn't put this one in the chat, but when I was doing my EMS training, actually, I live in Nash County, like I said earlier, and we had a cardiac arrest. It was my second call with EMS, and it took us 30 minutes to get him to the hospital. And because of that, he passed away. I feel like we could have saved him if he had lived closer to a hospital, because we did give him nitroglycerin and he was doing better, and then he decompensated right back into it all over again.
Yeah, there are certain conditions like a cardiac arrest and a stroke where, time is so valuable. I mean, the other condition actually is pregnancy. And so I meant to say that earlier. If you look at women that are at least 30 minutes from a delivery hospital, their health outcomes are substantially worse. And in Western North Carolina, as we've seen across North Carolina, there have been a lot of obstetric units closing. And so we've had actually 6 obstetric units close in the past 5 years. And so that makes a big difference. And I think it's complex why those maternity units close. Many times it has to do with finances. Sometimes it has to do with being able to really have qualified staff. Other times it'll have to do with like nursing staff, but sometimes it'll have to do with pediatric staff or anesthesiologists. And so I think, if you took a step back and looked at this as a whole, you would want to make sure that the most time-sensitive things have some sort of system in place so that they can be recognized really quickly, and transportation to an appropriate setting happens as quick as possible, and that all the professionals are trained at the top of their license to be able to deal with all those emergencies. In rural medicine, as it is actually in emergency rooms as well, you have to have some system for training for those rare occurrences that are life-threatening. Like that's the thing that you rarely see, but is life-threatening. And that's probably the most important thing to remember. So what other questions you guys have? It looked like a lot of chatter was dealing with this transportation. Do you guys mind, Phil, while she's asking the question, can you guys put in the chat like what you guys aspire to be, or what you're thinking about considering becoming in the future? And then Kaylee, is that you that was going to talk?
Yeah, I was just going to add, I recalled a map that we were shown in one of my other classes, and it showed how North Carolina's population is really migrating towards Charlotte, Raleigh, and I believe Asheville. So those rural areas are just getting much more rural by the year. And it was kind of insane to see, because I'm from Union County, so we're right near Charlotte, and I can see how it's developing and growing each day just around Charlotte and the surrounding counties. So those much more western counties and eastern as well, they're just getting much more rural by the year.
Yeah, I think Charlotte, pretty consistently is one of the most fastest growing, I think it's one of the fastest growing cities in the country, correct? Yeah, I think it'll be interesting to see how that trend changes with the advent of COVID-19, because we are starting to hear that people are leaving some of the urban centers for a little bit more private way of life, and that at least people have been talking about some rural redistribution just because of that. So it looks like we have oncology and cancer. So, regardless, a lot of cancer centers are going to be in major academic centers, but honestly, I think it's going to be important for you to recognize that you're going to want to make sure that, you're going to be taking care of patients that are rural as well. So whether they're coming to you or you have some way to do outreach one day a week, it's going to be really important to make sure that occurs. I think when we look at the numbers and there's clearly actually a rural disadvantage for cancer. I think that there are probably some real easy interventions that we could do just to make prevention more readily accessible for rural communities. But I think we also have to look at, how do we make sure that, anyone living in the US has equal opportunity for some of the greatest advances that we have in cancer care. It looks like we got Yuna's wanting to be a primary care physician. That's great. Rural family medicine, Elizabeth, love it. Primary emergency medicine in a rural area. I mean, I think that, so a lot of people will be attracted to emergency medicine because it can be a very, it's good for lifestyle because it's a lot of shift work. That being said, I mean, I think emergency medicine ends up having some of the highest rates of burnout. If you do go into something like family medicine, I think that you still can do some emergency medicine, especially in rural environments and in some smaller hospitals. And so I think that, all those things would be available. And a surgeon of some kind. I mean, so rural surgery is actually something that is really needed as well. And so MAHEC has just developed a general surgery residency program. And we're doing that because actually one of the highest needs for physicians was actually general surgeons in rural environments. And so you hear stories of surgeons in some of these rural environments where, they're doing, their first assist for the C-sections because, there aren't enough OB-GYNs out there. And I think, by happenstance, I grew up in suburban St. Louis, but I went to medical school in a more rural environment, and I did actually a lot of rural rotations. And I just saw that I really liked the way, the manner in which everybody was so congenial with one another, and really embrace the idea of taking care of the whole population. And so I definitely, at an early stage, I saw instances where surgeons and family docs were working side by side to really provide the best care possible. And I think you can do more in rural areas. And I think emergency medicine is definitely going to be something that, in so many different environments, you can practice. So I think that we're definitely seeing that. Just out of curiosity, how has the recent pandemic affected your desire to go into medicine, just across the board?
I guess for me, like when looking at the pandemic, I think it kind of exposes a lot of the shortcomings in our healthcare system. So for me, that motivates me to go into medicine even more. And like beyond like personal practice stuff, maybe looking at like public health stuff, and I guess figuring out like helping establish policies and stuff on a wider scale that solves like the bigger problems. That's for me at least. So
What about others?
Yeah, I think like Mohammed said, it made me realize that public health needs to be improved a lot more. And maybe want to enhance my desire to practice medicine more.
Yeah, I mean, I think that it's brought to light to me just kind of how urgent how urgent we should be for change, because we have a lot of resources and I think we can do better. And so this pandemic has kind of exposed some of the weaknesses in our system. And I feel fortunate in many ways. It's been, I've been able to, safely practice and see patients in the hospital and also in my practice, do more telehealth. I like to see that, because of the pandemic, we're having some of these harder conversations and trying to change the system. So at the same time, it's unfortunate that it's taken this. And I, for you all to say like, oh gosh, this kind of this energizes me even more. I mean, you all are the type of people that we definitely need to help us keep this change going. So.
Something I wanted to ask you about. So earlier we were talking about like accessibility to healthcare, and then Ryan was talking about like, oh, like these emergency situations where it just takes too long to get to the hospital in time. I know you were talking about like establishing like decentralized healthcare systems, but at the same time, when it comes to emergencies and stuff, um, like a decentralized system probably wouldn't have like it wouldn't like most of the time like the smaller clinics and stuff, they won't have like these bigger things needed in emergency situations. So what do you think would be like a solution for that? Like, do you think maybe the issue is transportation, or like I guess like in terms of like EMS, like roads, like what do you think is the solution for that?
It's a great question. Like, so if you took a step back and tried to design the system, right? And you said, okay, we have to get everybody to a place that could take care of a heart attack within an hour for stabilization, right? Or I don't know if an hour is enough, but at a minimum. So, I mean, then you could, map that out and try to figure out, all right, well, where are the spots, where are the cold spots on this map where it's going to be really challenging, and perhaps you set up EMS there in a different way, so that you could make sure that you could get the transport quickly. I mean, I think that we have great power and great technology at this point to kind of solve some of these key questions. It just takes them out of the box thinking. So that being said, I mean, the trend for more hospitals to close does become a little bit more concerning. And I don't know where the right, not every hospital is going to have a physician that can do a catheterization, right? Which would be the intervention that you want. Certainly not every hospital is going to have the ability to do open heart surgery, right? And so I think we just have to be thoughtful about the manner in which we kind of design our systems and think through these problems. And right now, I would say it's just kind of up to chance and economics, which I don't know if it is the best way to make those decisions. So I think that we're reliant on the people of our communities to speak up and say, no, this hospital can't close, and no, we can't lose another cardiologist. We need to be able to recruit, because if one of us has a heart attack, we're 2 hours away from the nearest place for treatment, and then people will leave and move away from the area. And I think we've seen that. So obviously a complex problem. So that's a great question. No more questions from Muhammad. Let's keep him on mute. He's asking too difficult of questions. What other questions do you guys have? Great questions, Muhammad.
There is one in the chat, Dr. Hodge.
Helicopters. And this is another good question. So helicopters they're tricky, honestly, especially in the North Carolina mountains. And so in some places they can make a lot of sense, but in many rural environments, there are some, challenges with weather, mountain passes, all of those things. So there are lots of instances where ground transportation can even be suspect as well. And so we've had cases where, there's been floods that have closed mountain roads, which are the only way in and out. And so, helicopters are certainly a tool that we can use to help address some of these issues. But on a clear sunny day with not much winds, it's a perfect solution. But we have to kind of have some fail-safe plans for bad weather as well. And I think as you're thinking through these, I think one of the cornerstones to problem solving has got to be like, how do we think upstream? And so actually, like, the best way to prevent that heart attack from happening on the dock of that lake in the rural environment is, how do we like take a step back and say, okay, how do we prevent smoking in our communities? How do we promote access to preventative measures like having a primary care physician, and promote healthy habits that are going to prevent those heart attacks from occurring in those real isolated areas? And so I think in order for us to effectively solve our problems, we really have to think about it from many different angles. Because, we can poke holes in a lot of different ways that, we're not able to fully address things by, helicopters alone.
All right, do we have any final questions for Dr. Hodge? I know we're getting close to 4 o'clock.
I was just gonna ask really quick, how do you think like corporate healthcare as a whole is impacting these rural communities?
You guys are really, really smart, and just that is an outstanding question. So we have a capitalistic healthcare system, which in many ways probably drives innovation. It should drive like really customer-centric innovation as well. But I think there are a handful of challenges with that. Like transparency with how and who has access is an issue. What the trends that we're seeing is, 50 years ago, if you would graduate from medical school, there's a good chance that you may not even go into a specialty, or you just go into general practice, and you would go, rent out some space and hang a shingle. The day of that is kind of come and gone in many ways. And so most physicians these days are employed by a larger corporate entity. And most of the time that's either a hospital or an FQHC. And I think we'll have to continue to challenge ourselves as we look at what each of those entities says their mission and vision is. Really will determine, kind of the degree in which we're able to see through what the reason why we went into medicine. So, I think it's changed the way we deliver care. I think it is driving, in many respects, the way that we deliver care. I imagine there will continue to be policy changes and different infrastructure, as we're already seeing with expansion of Medicaid and those types of policy issues. I honestly think, at the heart of it, I really think every American probably should have access to some essential services. And I think that those would be things like, the ability to get standard preventative services like pap smears, mammograms, colonoscopies, things that save lives. I actually think that that's in our best economic interest to do those things, because I'd much rather spend that money on an ounce of prevention than to deal with the repercussions of morbidity associated with bad outcomes. And so, so I think that, I think we have to be conscious of the manner in which our system is changing. And I think we also have to be advocates, not only for ourselves, but also for the patients that we're trying to serve. And so I have no doubt that you all will be walking that walk and probably solving some of those problems that either we haven't been able to solve ourselves in my generation, or haven't been strong enough to solve ourselves. So. Callie, did I answer your question, or did I kind of talk around it?
No, that was good. Thank you.
All right. Well, you guys have a bright future ahead of yourselves, and I'm honored to touch base with you guys today. Certainly, Ryan, please feel free to distribute my email, and I'm happy if you guys have questions to follow this up in any way.
Yes, sir, we can do that. Thank you very much for joining us today, and thank you for answering all our questions. Go ahead. Let's see. All right. Well, we just got a couple more things before we wrap up.
Thank you, guys.
Sure thing. Have a good day, Dr. Hodge.
Take care.
All right. So after that conversation, I did want to bring in Elizabeth Medema, who was my co-president last year for Rural Health Outreach Club and is now president, just to discuss what our meeting is going to be about on Wednesday.
Hi, everyone. My name is Elizabeth, and on Wednesday, we're having a Rural Health Outreach Club meeting. It's going to be at 7 p.m. and the Zoom information is there, but we are having a speaker who's a cardiologist in a rural area in Kinston, North Carolina, and he's going to come talk about some of the challenges that he has dealt with practicing rural medicine. And so if Dr. Hodge spurred any interest in rural medicine, we really hope you would join us on Wednesday and learn more about what our club is about.
All right. Thank you, Elizabeth. And Mohammed, I will pass it over to you.
All right. Well, thanks everybody for coming. Once again, going to shout out the Instagram at NC State Pre-Med. We always send out the posts when our meetings are coming up, things like that. So for the latest updates, you want to follow us on Instagram. You can email me and Ryan about just about anything when it comes to pre-med stuff or related to the club. Our emails are right there. And I'll send out an email at the end of the week with the Zoom recording, the slideshow, and hopefully Dr. Hodge's Prezi. That was a pretty good presentation, so I think we should get a hold of that. Other than that, this was our last meeting of the semester, so stay safe, everybody. Good luck with your finals and everything. Have a good winter break, and see y'all in the spring.
Thanks, y'all.